Welcome back to the deep dive. Today we're really zoning in on a specific congenital heart condition, tricuspid atresia.
That's right. We're going to unpack it using medical revision notes as our guide, aiming for that high-yield understanding.
Exactly. Think of this as getting the core information, the essentials you really need to grasp about this condition.
Mm-hmm. So our mission, if you will, is to walk through it clearly. Definition, causes, effects, diagnosis, treatment, the whole picture, but concisely.
Perfect. Let's dive right in. Definition first. What exactly is tricuspid atresia?
Okay, so at its core, it's a congenital heart defect. That means it's present at birth.
Right.
The main issue is the tricuspid valve. Normally, this valve sits between the right atrium and the right ventricle. In tricuspid atresia, this valve is either completely absent or it's abnormally developed, basically blocked.
So blood can't flow the usual way between those two chambers.
Precisely. There's no direct path. So the venous blood coming back to the right atrium, it has to find another way out.
Like an escape route.
Kind of, yeah. It usually has to cross over to the left side of the heart through some kind of opening between the atrial septal defect, or ASD, for example.
Okay, that makes sense. And the notes mention other heart issues can sometimes happen alongside it.
Yes, that's important. It doesn't always occur in isolation. You can have other cardiovascular anomalies too, which definitely adds complexity.
Like what, for instance?
Well, a significant one mentioned is transposition of the great vessels. That's where the aorta and pulmonary artery are switched. So you can imagine that complicates the blood flow even more.
Wow. Okay, so that's the what. Now, what about the why? Do we know the cause?
Well, the short answer is not exactly. The precise cause isn't known. It's thought to be multifactorial, likely a combination of genetic predispositions and environmental factors interacting during that critical window of heart development in the fetus.
So not just one thing, but a mix of influences.
Exactly. And it can sometimes be associated with other congenital heart defects or even broader genetic syndromes, which points to how complex heart development is.
Right, interconnected processes. Are there specific things that increase the risk? Any known risk factors?
Yes, there are some identified risk factors. Family history is one. If there's a history of congenital heart defects in the family, the risk is slightly higher.
Okay, the genetic link again. What about things during pregnancy? Maternal factors?
Definitely. Certain things related to the mother during pregnancy seem to play a role. Exposure to specific medications or substances, for instance. Maternal diabetes is another one, especially if it wasn't well controlled. Also, things like getting rubella during pregnancy or even advanced maternal age have been associated with a higher risk.
So, various potential influences during that key developmental time. Let's shift to the pathophysiology, what's actually happening inside the heart.
Okay. The central issue, as we said, is that blockage. Blood can't get from the right atrium to the right ventricle, so the body has to compensate. Blood gets rerouted through these abnormal pathways we mentioned.
The shunts.
Exactly. An atrial septal defect, ASD, allowing blood to cross from the right to the left atrium, or sometimes a ventricular septal defect, VSD, an opening between the ventricles, or even a patent ductus arteriosus, PDA, which is a connection between the aorta and pulmonary artery that normally closes after birth.
And these shunts are crucial because
They allow blood to eventually reach the lungs to get oxygenated and then get out to the rest of the body. It's the body's way of trying to maintain circulation, even with the primary pathway blocked. A survival mechanism, really.
incredible how the body tries to adapt. Now, when doctors suspect something like this, what other conditions might they be thinking of? What's in the differential diagnosis?
Good question. It's crucial to differentiate because the treatments vary. Key differentials include pulmonary atresia.
Where the pulmonary valve is blocked.
Exactly. Also, Ebstein's anomaly, which is a different kind of problem with the tricuspid valve itself. It's malformed and displaced. And critical pulmonary stenosis, which is a very severe narrowing of the pulmonary valve.
So similar presentations sometimes, but different underlying problems?
Precisely. Getting the right diagnosis is step one for the right management plan.
Makes sense. How common is tricuspid atresia?
It's actually quite rare, relatively speaking. The notes say it accounts for about 1% of all congenital heart defects.
Only 1%.
Yeah. And worldwide, the estimate is roughly 1 in every 10,000 live births. So not common, but significant when it occurs.
Got it. So when it does happen, how does it typically show up? What are the clinical signs?
Well, a major sign is often cyanosis, that bluish tinge to the skin, lips, nail beds. That's because of the low oxygen levels in the blood.
Okay, the lack of oxygenated blood getting around.
Right. You might also see rapid breathing tachypnea. Babies can have trouble feeding, poor weight gain, what we call failure to thrive.
Hmm.
Over time, if it's not addressed, you can see clubbing of the fingers and toes. And signs of heart failure can develop too, like swelling or difficulty breathing.
Are there more specific things a doctor might pick up on examination?
Yes, definitely. It's usually picked up in infancy. An examination might reveal elevated jugular venous pressure. You can sometimes see the pulse in the neck veins.
Okay.
You might feel a really prominent heartbeat on the left side of the chest. That's the left ventricle working overtime. The liver might be enlarged and possibly pulsatile.
And listening to the heart, any specific sounds?
Heart sounds can be revealing. Often the first heart sound is single and might be louder than usual. The second heart sound might also sound single or maybe just narrowly split.
What about murmurs?
Murmurs are common. A pansystolic murmur, one heard throughout the contraction phase, is typical if there's a VSD.
Right, the shunt between ventricles.
Exactly.
Yeah.
You might hear a continuous murmur if there's a patent ductus arteriosus, that PDA connection. And sometimes, though less common, a murmur of mitral regurgitation, perhaps due to the increased workload on the left side.
Okay, that paints a clearer clinical picture. So, if these signs are present, what investigations are ordered?
A range of tests are needed. A full blood count, or FBC, is important. It might show polycythemia.
More red blood cells.
Yeah, the body tries to make more red blood cells to carry more oxygen, compensating for the low levels. Blood gases are also key. They'll likely show hypoxemia, the low oxygen, and possibly acidosis.
And imaging, I assume that's crucial.
Absolutely. A chest X-ray, CXR, is standard. It often shows cardiomegaly and enlarged heart. You might see a prominent right heart border because the right atrium is enlarged. And typically, the lung fields look like they have less blood flow, so diminished pulmonary vascular markings, unless, of course, there's a large shunt keeping pulmonary flow high.
What else? ECG, echo.
Yes, an electrocardiogram, ECG, looks at the heart's electrical activity. But the real star is the echocardiogram.
The ultrasound of the heart.
Exactly. It's non-invasive and gives incredibly detailed pictures of the heart's structure, the valves, the chambers, the connections, and how well it's pumping. It's usually the key diagnostic tool.
Okay.
Sometimes cardiac catheterization might be needed too. It's more invasive, involves threading a catheter into the heart, but it gives very precise measurements of pressures and oxygen levels and can help plan surgery.
So all these tests together build the full picture: anatomy, function, severity, any other issues. Right, let's talk management. What's the approach?
Management is usually a multi-step process. It starts with immediate stabilization, especially for newborns who are very sick.
Okay, what does that involve?
If the baby is very blue, meaning severe hypoxemia, and relies on the ductus arteriosus for blood flow to the lungs, giving prostaglandin E is critical. It's a medication that keeps that ductus open.
Buys time, essentially.
Exactly. Oxygen therapy is given as needed. Preventing infections like bacterial endocarditis is important, and managing any signs of heart failure with medication.
And then comes surgery.
Yes. It's typically a staged surgical approach, usually happening over the first year or so of life. It's not a one-and-done repair usually.
Can you walk us through the stages briefly?
Sure. Stage 1 often involves creating a shunt to get more blood to the lungs. The classic one is the blaloktothic shunt, or BT shunt. It connects the systemic artery to the pulmonary artery.
Okay, boosting lung blood flow.
Right. Then stage 2 is often the bidirectional Glenn procedure. This connects the superior vena cava, the large vein bringing blood back from the upper body directly to the pulmonary artery. So that blood bypasses the heart and goes straight to the lungs.
I see. And the final stage?
The final stage is the Fontan procedure. This is the big one that aims to separate the systemic and pulmonary circulations as much as possible without a functional right ventricle.
How does that work?
It directs the blood from the inferior vena cava, the vein bringing blood from the lower body, also to the pulmonary arteries. So now pretty much all the blue blood goes directly to the lungs without passing through a pumping chamber on the right side. There are different ways to create this Fontan connection.
A complete rerouting, essentially.
Pretty much, yes. And after all this, lifelong follow-up with cardiology is absolutely essential for monitoring.
It's incredible surgical planning. What's the long-term outlook, the prognosis after these procedures?
Well, the prognosis really depends on the specific anatomy, any associated defects, and how well the Fontan circulation works long-term. But the surgical outcomes themselves have improved dramatically.
That's good to hear.
Yeah, the notes mentioned that the perioperative mortality for the Fontan procedure itself, meaning death around the time of surgery, is now generally below 2%. That's a huge improvement over past decades.
That is encouraging. But are there still potential complications down the road even after successful surgery?
Yes, unfortunately, the Fontan circulation isn't perfect, and long-term complications can arise. Cardiac issues are common.
Such as?
Things like heart failure can still develop. Arrhythmias, or irregular heart rhythms, are quite common. Pulmonary hypertension, high pressure in the lung arteries can be a problem. The heart chambers can dilate. The ventricular function can decline over time. And the mitral valve on the left side might start to leak.
So ongoing heart monitoring is key. Any non-cardiac complication?
Yes, developmental delays can occur in some children. There's a lifelong increased risk of infective endocarditis, that heart valve infection. And because of the altered circulation, there's a risk of blood clots forming and potentially traveling to the brain. These are called paradoxical emboli, which can cause stroke or, rarely, brain abscess. And that polycythemia we mentioned earlier can persist or recur.
A lot to keep an eye on throughout life then.
Absolutely.
Yeah.
Regular, specialized follow-up is crucial.
Okay, so let's recap. Tricuspid atresia, the tricuspid valve is missing or blocked. Blood flow is rerouted through shunts. Causes are complex, likely genetic and environmental. Diagnosis relies heavily on echocardiography. Management involves initial stabilization, often with prostaglandins, followed by stage surgeries, typically a shunt, then Glenn, then Fontan. Prognosis has improved, but long-term cardiac and other complications require lifelong care.
That's a great summary. It highlights the journey from diagnosis through complex management to long-term follow-up.
It really underscores the adaptability of the circulatory system and the incredible progress in pediatric cardiac surgery.
Definitely. The Fontan circulation itself is a remarkable concept, allowing survival and relatively good quality of life for many, despite missing a functional right ventricle.
A final thought for our listeners. Maybe consider just how these complex reconstructions function long-term and the ongoing research aimed at improving life for individuals with single ventricle physiology. It's a constantly evolving field.
Well said. There's always more to learn and improve upon.
We really hope this deep dive has helped clarify tricuspid atresia for you. For more revision resources, definitely check out Pathophysiology.com.
And don't forget, freemessery.com for free questions and materials too.
Thanks for tuning in to The Deep Dive.